Bismillahirrahmanirrahim. In this video, we will discuss the systemic effects of inflammation. Following are the references for this video. So the learning objective for this video are to describe the key systemic manifestation of inflammation, including fever, acute phase response, leukocytosis, and sepsis, to explain the underlying mechanism of systemic effects such as cytokine release and their role in mediating fever, hepatic protein synthesis, and hematological changes, and to differentiate between normal systemic response to inflammation and pathologic conditions such as systemic inflammatory response syndrome and septic shock. The acute phase response is a term that is given to systemic effects of inflammation. It can be defined as cytokine-induced systemic reaction associated with inflammation, or it can be defined as a systemic cytokine-mediated response to localized or widespread inflammation that is triggered by inflammation, trauma, or other inflammatory stimuli. The key mediator for these responses are TNF, interleukin 1, interleukin 6, and type 1 interferon. The effects that are produced are fever, acute phase protein formation, leukocytosis, increased pulse, increased blood pressure, decreased sweating, shivering, chills, anorexia, somnolence, and malaise. The fever is manifested by cytokines interleukin 1 and interleukin 1 and TNF. It stimulates prostaglandin synthesis in hypothalamus. Increased heart rate and BP are due to sympathetic activation. Decreased sweating is due to blood flow that is redirected from the skin to conserve heat. Rigors of shivering are rapid muscular contraction to increase the body temperature. Chills are behavioral search for warmth. Anorexia, somnolence, and malaise are cytokine effects on CNS. Then there is production of acute phase protein. Liver produces CRP, fibrinogen, serum amyloid A, and under the interleukin 6 stimulation. These systemic effects can be memorized by a mnemonic that is firm chaps, like a tough cowboy fighting inflammation. So these firm chaps, F for fever, I for increased heart rate and blood pressure, rigors, malaise, chills, hypohidrosis, for H that means decreased sweating, A for anorexia, production of acute phase protein, and just to recall, interleukin and TNF increases prostaglandin in the brain that causes the fever, and increased heart rate and blood pressure is due to cytokine induced sympathetic activity. Rigors, shivering from muscle activity to raise the body temperature. The patient is feeling unwell due to cytokine effect on the CNS. Chills are behavioral response to feel warmer. Vasoconstriction divert blood from the skin to the organ. Loss of appetite due to central. Then there is production of acute phase protein, CRP, fibrinogen, serum amyloid, etc. And cytokine induced increased sleepiness causes somnolence. So how this fever is developed during acute inflammation? The pyrogen that can be exogenous or endogenous. The exogenous pyrogens are lipopolysaccharides of the bacteria, while the interleukin 1 and TNF that are released during acute inflammation, they act like endogenous pyrogens. So these pyrogens, they act on arachidonic acid, and by the action of cyclooxygenase enzyme, they they form prostaglandins. Prostaglandin, especially prostaglandin E2, it is released by hypothalamic vascular and perivascular cells especially, and they will result in increased formation of neurotransmitter substances, and this will result in an increase in the body temperature that is usually 1 to 4 degrees centigrade, and this is because these neurotransmitters, they reset the thermoregulatory set point to a higher temperature. So there is development of the fever that helps to limit the microbial survival and may enhance the immune response. Non-steroidal anti-inflammatory drugs such as aspirin inhibit COX enzyme, and this cyclooxygenase enzyme inhibition will result in decreased prostaglandin synthesis, so the fever or temperature is decreased. These steps of the fever production can be memorized by the mnemonic lemon H. Uh, the lemon H is L for lipopolysaccharide, endogenous pyrogen for E, macrophage cytokines for M, oxygenase, the cyclooxygenase enzyme for O, neurotransmitter release N, and finally there is hypothalamic thermostat that is set to a higher temperature, and that induces fever. The acute phase proteins are produced by the liver, and they are actually the plasma proteins. Uh, these can augment the inflammatory response about 100 times, and the major plasma proteins or acute phase proteins are C-reactive protein, fibrinogen, and serum amyloid A protein. Principally, the interleukin 6 is responsible for elevation of fibrinogen and CRP, C-reactive protein, while interleukin 1 and TNF are responsible for serum amyloid A protein. They are responsible for attachment to the microbial cell wall, so act as opsonin and hence fix the complement, and these may attach with the chromatin, hence they are helpful to clear away the necrotic material that is present at the site of the uh, damage. Then fibrinogen binds with the salic acid on the RBC surface. This salic acid surface, RBC surface, so there will be a rollo formation like a stack of the coin. These form rollo, these RBCs. So the ESR in inflammatory conditions in increase, there will be early sedimentation due to increased aggregation of these RBCs. Then these inflammatory mediators, acute phase proteins, the acute phase proteins, these when produced, they have got a beneficial effect on the inflammation because they are first they are enhancing or augmenting or amplifying the inflammatory response. But simultaneously, if there is prolonged activation, this can lead to deposition of these abnormal proteins that are called as amyloid protein, and this is one of the cause of secondary amyloidosis. Then there is risk of MI and C That means that elevated levels of CRP are considered sometimes as a marker for myocardial infarction in the patient that are having coronary artery disease. So, in the presence of atherosclerotic plaque, if there is inflammation, that predisposes a patient to the uh, first to the damage or increase in size of the atherosclerotic plaque, and then the necrosis. The hepcidin binds to ferroportin that are the only known iron exporter that are present on intestinal enterocyte that are responsible for absorbing dietary iron, and they are also present on macrophages, an important cell for the recycling of the iron from old RBCs. They are also present on hepatocytes for storing of the iron. Binding of these hepcidin causes internalization and degradation of the ferroportin, and as a result there is decreased iron absorption and iron released, so decreased plasma iron level, and as in chronic inflammation interleukin 6 causes increased hepcidin, so iron is decreased. Uh, by this mechanism there is development of anemia, so anemia of chronic disease develops. In iron deficiency or hypoxia, the hepcidin is decreased. So whenever there is decreased hepcidin, the ferroportin are increased. So iron is available for erythropoiesis. This is the compensatory mechanism for this. So there are many acute phase protein. These are mannose binding proteins that opsonize and activate complement. C-reactive protein are responsible for opsonization. Alpha 1 antitrypsin, they are actually serine protease inhibitor. Heptoglobulin binds hemoglobin. Ceruloplasmin is antioxidant and also binds copper. Fibrinogen is activated with coagulation. Then serum amyloid A protein, apolipoprotein. Alpha 2 macroglobulin is antiprotease, and cysteine protease inhibitor is also an antiprotease. Now, to conclude this discussion on acute phase protein, these interleukin 6 are responsible for increased CRP and increased fibrinogen, while interleukin 1 and TNF are linked with serum amyloid A increased quantity. The C-reactive protein that bind with the microbes and then opsonize these microbes, and hence they are easily degradable and complement is fixed. So remember that this is the marker of inflammation and there is increased cardiovascular risk, especially of MI. Serum amyloid A it also causes opsonization and it recruits more uh, immune cells. If there is prolonged elevation of the serum amyloid A, there will be development of secondary amyloidosis. Fibrinogen binds RBCs and is responsible for rouleau formation, and there will be increased ESR. So ESR is an important test, though non-specific, but it is important test that is linked with inflammation. Hepcidin, another acute phase protein. Whenever there is decreased absorption and release, it limits bacterial growth, and it is when it is increased chronically, there is development of anemia that is called anemia of chronic disease. So the acute phase proteins can be memorized. The important one can be memorized as CHIPS. So C is for CRP, hepcidin, SAA or protein A, and S is sedimenter, the fibrinogen that causes increased ESR. So leukocyte is another common feature of inflammatory reaction, especially this is common one in those inflammations that are induced by bacteria. Uh, Usually it climbs up to 15 to 20,000 cells per microliter, but may increase up to 100,000 in inflammation. This There will be accelerated release of cell from the bone marrow that is going to combat the invading of foreign agent, and this is by the interleukin 1 and TNF to recruit more cells. If there is a band form or large number of neutrophils seen in the peripheral film, it is termed as left shift. More cells that are of immature type. Then if it is prolonged and increased colony stimulating factor, there will be increased proliferation of precursor in the marrow, and the various type of the cells are released into the bloodstream or to travel to the site of the infection. Neutrophilia is seen in bacterial infections, while the lymphocytosis is characteristic of viral infection such as infectious mononucleosis and mumps. Eosinophilia is seen, or presence of eosinophil in the blood is seen in allergies and parasitic infection, while leukopenia is seen in some infection such as typhoid fever, rickettsia, and some viruses. Whenever there is dysregulation of the inflammation, there will be increase or decrease in inflammation. When there is excessive inflammation that occurs in severe infections or dysregulation of the immune system, such as occur in septic shock, the triggers of these excessive inflammations are TNF and interleukin 1. TNF and interleukin 1. So the blocker of these cytokines are also used in the sepsis and the crisis conditions that occurred in COVID-19. Then the clinical triad that is associated with this is disseminated intravascular coagulation, hypotensive shock, and metabolic disturbances such as insulin resistance that contributes to hyperglycemia. A condition that is termed as cytokine storm is developed when large amount of bacteria and their products are present in the blood, and due to these there is massive production of cytokines, especially tumor necrotic factor and interleukin 1. So there is development of a triad, the DIC, hypotensive shock, and hyperglycemic state due to resistance to the insulin, and these all three contribute to septic shock. Defective inflammation occur due to insufficient immune response, and the host now become vulnerable to infection. So it can occur due to suppression of the bone marrow, as occurs in leukemia, metastatic cancer, in which the most of the bone marrow is replaced by the tumor cells, and chemotherapy or immunosuppressive therapy. Inherited disorders such as leukocyte addition deficiency and chronic granulomatous disease are also the causes of defective inflammation, and these defective neutrophils, the defects of the neutrophils, I have made another video for these defects of the neutrophils that is available in playlist. So complement deficiencies are also associated with defective inflammation. A separate video for complement system is also available in the playlist. Thank you for watching this video. If you have any query, please write in the comment box. Thanks.